Welcome again, everyone, and thank you for helping us observe Older Americans Month this May. The National Caucus and Center on Black Aging, Incorporated, NCBA, and Dr. Cheryl Reynolds is hosting a webinar on what you should know about age-related macular degeneration as an older American. Our presenter today, Dr. Cheryl A. Reynolds, is a professor at Nova Southeastern University College of Optometry. She was a past president of the National Optometric Association, NOA. She is a planning group member of the National Eye Health Education Program, NEHEP, and is co-chair of NEHEP's Eye Health, My Health campaign that fosters eye health care for African Americans. Dr. Reynolds, thank you so much for joining us once again. We appreciate you, and the floor is yours.
Oh, thank you so much for having me. Good afternoon, everyone. It's indeed a pleasure to be back, invited by the National Caucus on Black Aging and the wonderful staff at this organization to present again on eye health issues. So we're going to spend the next maybe 30 minutes or so with a lot more time for questions and answers on talking about what you should know about age-related macular degeneration. And so it's interesting, age-related macular degeneration, as we talk about this topic, and May being Older American Month, it's being Healthy Vision Month. Each of these months have a significance. And so it's important. I always say that, for me as an optometrist and eye care practitioner, we do more than just save sight. We can save our patients' lives. So let's segue. Again, I am a professor at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida. And I'm past president of the National Optometric Association, an organization started over 50 years ago to really sort of advance the visual health of minority populations. So it's really a passion for me to be part of this discussion. And also, as spoken about, I'm part of the National Eye Health Education Program, NEHAP, part of the NIH, NEI. I'm also a co-chair of the Eye Health, My Health, which is an initiative focused on, eye health issues in minority populations, specifically African Americans. And just a little bit about the NEHAP, or National Eye Health Education Program. It was established in 1988. And, eye health education is so critically important. And so we promote eye health as a public health priority, prevent vision loss through outreach and education. Again, we have planning groups, we have partnerships. Our 6 program areas include diabetic eye disease, which is the leading cause of vision loss in our working age adults. Those are individuals 20 to 74 young, still working. Vision rehabilitation, which we'll talk about as we talk about macular degeneration, vision and aging, and of course that includes age-related macular degeneration, glaucoma, another leading cause of blindness. We call these the silent thief of blindness because there's really no symptoms. We have programs focused on eye health for our Hispanic, Latinx, Latino community, and then again, my eye health, my health, which is eye health for African Americans. So I want to start off, I always do this when I do these webinars by just asking a question to the audience member. And you can put your answers in the chat if you so desire. But the key question is, do you, a family member, or do you know someone that has age-related macular degeneration? So let's see how many of you in the chat have answered that question. All right, I see some yes there. Okay. We all know someone that is impacted from eye disease, whether it's glaucoma, diabetes impacting the eye, diabetic retinopathy, diabetic maculopathy, as we spoke about on other webinars, or glaucoma. But age-related macular degeneration is one of those conditions that's really common in our aging population, and no one let me repeat that. No one is immune from getting age-related macular degeneration. So let's talk about this disease. Again, it's a common eye condition, and it is the leading cause of vision loss or blindness amongst people 60 years of age or older. It damages a specific part of your eye called the macula. And that macula, and I'll show video, but it's that area in the back of your eye that is the most sensitive. It allows you to see central vision. It allows you to see detail, color vision when you're reading. Your macula is so important. So certain diseases, such as age-related macular degeneration, can impact that area. So you can lose your central vision, but still have your peripheral vision. So it doesn't completely rob you of your total sight, because you still have peripheral or side vision, but it robs you of your central vision, as opposed to glaucoma, which is an eye disease that impacts the optic nerve in the back of the eye. And because that optic nerve is impacted, you tend to lose your peripheral vision. So patients with glaucoma tend to lose their side vision. They may bump into things, while patients with macular degeneration or diabetes impacting the macula tend to have central vision loss. So they don't have sharp, clear vision, and it can really impact their quality of life. And we'll talk about that as we go through the presentation. It can interfere with their ability to see faces. You know, just looking at someone, talking to them is part of your macular function. Your color vision and detail, that's part of your macular function. So it may impact their ability to drive, their ability to read, their ability to write, do close-up work, things that they love to do, like cooking and sewing or fixing things around the house. So it really can impact their quality of life, and not just their quality of life. A lot of these patients may have, mental health issues or other issues because of their macular degeneration. And I see in the chat that, again, some yes, some patients, some individuals say, I don't know. And then my mother had macular degeneration. And that's important, because when we look at the risk, one of the risks is family genetics. So again, macular degeneration, when you look at this schematic here, this is an eye. I would say the eye is like a ball shape, the front part of the ball, where you have your cornea, you have your lens. When we say someone has cataracts, it's the lens that becomes cloudy over time, and then they need cataract surgery. And then, of course, here's your retina. Your retina is a very thin membrane in the back of the eye. Here's your optic nerve. This is what is impacted when a patient has glaucoma. And then, of course, here's your macular area. And you can see that it's relatively a small area in the back of the eye, but that small area is so significantly important for our quality of life and our visual function. I'm going to see if this video plays. It's from the NEI, so it kind of goes over age-related macular degeneration. So let's see.
Age-related macular degeneration, or AMD, is the leading cause of visual impairment and blindness in older Americans. It affects the retina, the light-sensitive layer of the eye. In early AMD, yellowish deposits form under the retina. They can result in distortion and gradual blurring of vision. As the disease progresses, more and larger deposits develop, and blood vessels grow up from beneath the retina and leak blood. The leaked blood causes damage to the retina. In advanced AMD, peripheral vision may remain, but the ability to clearly see straight ahead is lost.
Okay, let's see here. I'll get out of here. 1 second.
Wayday's coming. Wayfair's biggest sale of the year is back.
Okay, so I hope that video kind of helps to explain age-related macular degeneration. I'll go over it a little bit more in detail. But like I said before, it's a disease that impacts that center part of your vision. What's important about age-related macular degeneration is that 20 million Americans in the United States have been diagnosed with some form of macular degeneration. And part of the reason we're seeing an explosion in the number of individuals being diagnosed is that our baby boomers are living longer. We have advanced care and medicine, so patients are living longer. We have advanced diagnostic armamentarium, so we're picking up diseases earlier and addressing them earlier. So that's why we see 20 million Americans having some form of AMD. The disease has different forms. I don't like to say good or bad type because they both can be bad and cause vision loss. But, some patients may have the type where there's bleeding in the eye, and some patients might have the type where the macula becomes atrophic or it doesn't work well. 2 million Americans have the advanced stage where it's impacting their vision. They have vision loss and or they're functionally impaired or they're blind from macular degeneration. 80% of vision impairment in patients over 60 is because of macular degeneration. And every year, 200,000 new cases are diagnosed in the United States. This is important. And when you look at February, again, we're talking about May being, aging month or growing up month is what I would say. But February as not only Black History Month, but it also is AMD or Low Vision Awareness Month. And this campaign just was rolled out in 2024. And that campaign really is to bring or highlight the importance of a comprehensive dilated eye exam in helping to detect macular degeneration, because 1 in 3 individuals over the age of 75 will have some form of age-related macular degeneration. So who is at risk? Who would get age-related macular degeneration? As I mentioned, no one is immune. We know that older Americans tend to have macular degeneration more so than our younger individuals. We do know that some younger individuals may have changes in the macula, that they have been told that they have macular degeneration. And I'll expand on that in just a few minutes. Race is an important factor. We tend to see this disease more in our Caucasian patients, more so than we do in our African American or Hispanic or Asian population, but it still can impact, and let me repeat that, it can still impact our Hispanic, our Asian, and our African American patients. So you on this webinar could be at risk for macular degeneration. Patients that smoke, we know that smoking doubles the risk of developing age-related macular degeneration. We also know that smoking is an important factor in exacerbating eye diseases such as diabetic retinopathy and glaucoma. So one of the key things that we need to do is talk to our patients about smoking cessation or quitting smoking. Obesity. Obesity can lead to a number of health issues and eye complications. We not only see obesity as a link when we talk about diabetes and the term diabesity to incorporate both as risk factors for type 2 diabetes, but in patients that have age-related macular degeneration, obesity is also a risk. And it's typically that central abdominal girth. So it's that bigger width of the belly area that's really important. And then last but not least, family history and genetics. This is a genetic disease. And what I tell my students all the time, it's not, when we say risk factors, only Caucasian patients. It's who's in the chair. If you have a biracial person or a person that has a very diverse family history, they could be at risk. When we think about a Barack Obama, he could be at risk for age-related macular degeneration because of his Irish component of his mother's side of his family. So it's a genetic disease. So having someone in your family with age-related macular degeneration puts you at risk, and you should be checked for that. As I mentioned, smoking is a big risk factor. UV exposure can also exacerbate or make things worse. And so can Blue light. We talk about taking time away from computers and iPads and iPhone because of blue light. So, using your iPad and iPhone a lot, especially as you're older, can put you at risk for progression of your age-related macular degeneration. We talked about older age, poor diet or unhealthy diet as a key contributory factor for a number of diseases, not just age-related macular degeneration or diabetes and diabetic retinopathy, hypertension, obesity. So eating healthy is really important. We'll talk about things that patients can do to help slow the progression of age-related macular degeneration, and that includes nutrition, in addition to eye-friendly vitamins or nutritional support. And then having comorbidities such as blood pressure, especially if your blood pressure is not well controlled, having diabetes, having high cholesterol, and I mentioned earlier about that central abdominal girth. Those are risk factors. We call them metabolic syndrome, risk factors for cardiovascular disease, but that can also put you at risk for progression of your age-related macular degeneration. What are some symptoms? Remember, I said the macula is responsible for your central vision. So patients with age-related macular degeneration may complain about blurred central vision. As you can see in this schematic, it's really hard for them to see center. They could see everything around them, but everything looks a little fuzzy in the center. And as the disease progresses, that's when it becomes even more noticeable and more of an issue for these patients. And then you can see here their peripheral vision is intact. They can see things around. It's just in the center that it's really distorted. As the disease progresses, sometimes, as I mentioned before, you can get bleeding in the center part of the macula, and it may cause fluid to build up, blood to build up, and so they may have wavy lines. Things may not appear as straight. They may have dark patches in the middle of words as they read. And then, of course, worsening in their color vision can occur. And again, this picture just kind of highlights that. Here's a patient without AMD, but because of the disease, they can't see that central part of this house because of the macula being impacted. So how do we check? How will your eye doctor check for macular degeneration? Well, visual acuity is always important, but visual acuity is just one part of it. You can be 20/20 and have early age-related macular degeneration. So of course, vision is important, but I always want to reiterate and make sure the audience understand you can be 20/20 or have good vision, have glaucoma. That's why we call it the silent thief of vision. You can have 20/20 for good vision and have a significant diabetic retinopathy or bleeding in the retina. So vision is not the biggest part of it. It's something that we need to check. And of course, it's important to get a dilated eye exam. Once you have your eyes are dilated, it allows the eye practitioner to look at the retina, to look at the macular area. If patients come in and they're complaining about wavy lines, we could do additional ancillary testing such as AMSA grid. Sometimes the patients might see wavy or loss of their central vision. And then, of course, your doctor might take a picture of your eye. So they may take a retinal camera, photography of your eyes, just so we can document that. And then, of course, you have other testing that is available, optical coherence tomography, and some other newer devices that your doctor may have available to help them detect macular degeneration. So what do we look for? Again, when we look in the back of the eye, we're looking at the optic nerve, we're looking at the blood vessel, and here again is that macular area. And so in this normal eye, you don't see any defects. It looks pretty normal. But a patient with macular degeneration will develop these yellow deposits. These deposits are called drusen. When I talk to my patients about these deposits, it's like tartar on your teeth. You develop it. It's an accumulation byproduct of the cells, and genetics can predispose you, age can predispose you to that buildup of that metabolic byproduct. And so you get these little yellow deposits in the macular area. Usually these yellow deposit could be circular. Again, the vision could be pretty good, for most patients that have 20/20 vision have no complaints, but sometimes these patients might have changes at these yellow deposit get bigger or there is more in number, and it can lead to bleeding in the macular area. So the term dry means that there's no bleeding or there's no fluid, but it also means these yellow deposits, because you have deposits that build up and you can't get oxygen to that area of the retina. But when you don't get oxygen to that area can become atrophic. And so if it becomes atrophic, then the patient can have loss of vision. Or, as I said before, they can develop new blood vessels in the back of the eye, and you have these areas of bleeding. Again, when we talk about macular degeneration, you can have early macular degeneration. Here's again another pictorial of the back of the eye. You could see these blood vessels. You could see here these yellow deposit, as I mentioned before. These are called drusen. Again, these deposits can be small, and again, patients can have good vision, or this deposit can be larger. They can coalesce, come together. I always say when you look at tartar on your teeth or plaque on your teeth, as it builds up, it gets harder, and it can become an area where you could see it, right? If you don't get your teeth cleaned. So same thing, that drusen can coalesce, come together and get bigger and get harder, and it can cause defects. And so here's a patient where, because those drusen areas are bigger, we call it intermediate age-related macular degeneration. So the size of these small defects are anywhere from 63 to 125 microns, but in intermediate AMD, they're greater than 125 microns. So they're just bigger in size. Because again, you have that buildup in the macular area, and there's different layers of the macula. You can't get oxygen to the outer retina from a part of the back of the eye. When you don't get oxygen, tissues can become atrophic or die. And this is what happens when you have buildup. The patient still has technically dry age-related macular degeneration, but this is the advanced form of dry age-related macular degeneration. So the term, when you have the tissue not working, is atrophy, and so we term it geographic atrophy. And then some patients with macular degeneration may have where there's bleeding in the eye. So they may say to you, I have bleeding in the eye, and I'm getting injections because I have bleeding in the eye or fluid in the eye. And that's here is a pictorial of the bleeding in the eye. And the bleeding is because, again, you can't get oxygen to that area. It's not working well. So the body says, all right, well, I can't get oxygen. So it develops these new blood vessels. That term neovascular it's really new blood vessels that are being created. And these new blood vessels are leaky and they bleed. That's why you get the bleeding in the macular area. So for patients with the earliest type, so when I go back again, if you look at this early type of macular degeneration, we can monitor this. We, as eye care practitioners, we thoroughly educate the patient. We photo document. We do additional testing for the patient. We give them an at-home AMSA grid, or there are other devices that they can use at home to help monitor their macular degeneration. And when we give these patients, educational information about better nutrition, we advise them about smoking cessation, and we may recommend multivitamins that has lutein and zeaxanthin, which are those two eye-friendly vitamins that can help, slow down macular degeneration. So we really talk to our patients about that, and we see these patients maybe every 6 months, just to follow up in the beginning of the visit or relationship with the patient, and then maybe we can lengthen it to 8 months sometimes, or even a year, depending on the patient and the testing results. And then for our intermediate patient, that is this patient here, you can see these drusen are really hard and larger. So for those patients, we may definitely want to do eye-friendly vitamins. The NEI, did a large study, and this study was the age-related eye disease study, looking at nutritional supplementation to help protect patients against the progression of age-related macular degeneration. And you found that introducing, certain vitamin component, your carotenoids, and zinc, copper, beta carotene, things of that nature can help. Now, AREDS 1 looked at beta carotene, but AREDS 2, for the age-related eye disease study, looked at lutein and zeaxanthine without the beta carotene. And again, you see patients taking that supplementation to help slow down the progression by 25%. Is what the study found. So when you look at the AREDS 2 formulation, you could see it has, vitamin E, vitamin C, it has lutein, zeaxanthine, zinc, and copper. And this is what we recommend for the patient, as well as eating healthy. Certain foods are good nutritional support. Your peppers, especially your colored peppers, is a good source of lutein and zeaxanthine. We talk to our patients about spinach and kale, more of your vegetable on your plate than the carbs on your plate. Again, for advanced age-related macular degeneration, and for those that have that advanced dry, injections will be the treatment, in some cases laser. For the advanced dry, there are new injections that just came on the market to give our patients with advanced dry that have geographic atrophy, especially early stages, hope in slowing down their disease. So, do lifestyle make a difference? Yes, I mentioned this before. We're talking about nutritional support, smoking cessation, UV protection, blue light protection. You can definitely avoid smoking, exercise regularly so that your BMI is in good shape, or you're at your BMI as you should be. Maintain your blood pressure and your cholesterol levels. And of course, eating a healthy diet rich in green leafy vegetables and fish can definitely help. I always tell my patients, you are your best advocate. So there are certain things that you need to talk to your practitioner about. Sometimes it's overwhelming to be told that you have an eye condition, but it's important that you talk to your doctor. What is the condition? Can you spell it for me? Allow the patient maybe to do some research, on their condition, to know their condition a little bit better. When your patients, or I tell my patients they have macular degeneration, they always want to know, can it be treated? Is there medicine I could take to stop it? Again, in the early stage of the disease, there's nothing except for incorporating those mitigating factors, smoking cessation, making sure your blood pressure, your cholesterol, and if you have diabetes is well controlled, eating healthy. Those are the things that you can do. For intermediate AMD, same thing, you want to take those eye-friendly vitamins in addition to doing what I just mentioned. Seeing your eye care practitioner a quick, every 3 months, 4-month follow-up just to make sure that your disease is stable. Making sure that you're doing those home AMSA grid. If you are giving those home AMSA grid, making sure each day you're checking one eye at a time, make sure there's no wavy line, no spots in the vision. Or if you have a at-home device that allows for better detection, to do those on a daily basis as well. And how will this condition affect my vision now and in the future? And that's important to ask the doctor. Right now, you see well, we want to maintain that. We want to slow it down. That is why it's important for you to take your eye-friendly vitamins and to follow up with your eye care practitioner on a regular basis. A close monitoring is very important for patients that have macular degeneration. If the patients have waviness in the line on the AMSA grid, or any missing spot or any changes in their vision, or if you've noticed it as a patient, you have to see your eye doctor back right away to make sure that your disease hasn't changed, hasn't progressed. So some symptoms: blurrier vision, the vision has changed, waviness. Your blinds, the blinds that you're looking at, they look wavy if you're not doing your AMSA grid. AMSA grid is important to look at. And then should I make lifestyle changes? Of course, exercise, taking your medication, healthy eating, those green leafy vegetables and fish are really important to slow down age-related macular degeneration. If you do progress or there are changes in your vision, like I said, there's new treatment for geographic atrophy or the advanced dry. You want to talk to your eye care doctor about that. If you have bleeding in the back of the eye for macular degeneration, the treatment will be injection in the eye. I always educate my patients about the injection. It doesn't really hurt. They numb the eye. The retinal specialist, so your optometrist, if you've seen an optometrist, will refer you to a retinal specialist. We work well together in making sure that our patients get the best treatment and timely prompt treatment. So they'll numb your eyes, they'll put the injection in of a substance that helps reduce those new blood vessel growth. You may have an injection every month, or you may have it every 2 months, and they have now available injection for every 4 months. So we can space out the injection a little bit longer based on how you, the patient, are responding to the injection. And that is by close monitoring with the retinal specialist. And, some patients, they are injected until there's decrease in the bleeding or the fluid in the back of the eyes. So you may get injections for a while. Like I said, now we have available every 4-month injection, which really helps with our patients and their family members, bringing them to the retinal specialist office. We can space out the injection as opposed to every month. What are the benefit of this treatment? It slows down the progression, and it is very successful. It's the latest treatment for age-related macular degeneration. And our hope and goal is to slow down the disease so that we can preserve your sight, preserve your quality of life and your function before the disease robs you of that. What are the risk and side effects of the injections? Again, the risk is maybe mild redness. You might feel, a little stinging. In some cases, patients might have more redness, but the side effects are very minimal. You should talk to your doctor about those side effects. Like I said, it's the latest treatment that the retinal specialists are doing for patients with macular degeneration. Should I avoid certain foods, drugs, and activities while I'm undergoing treatment? Yes, of course. You might want to, again, incorporate a healthier lifestyle. Stay away from your pizzas and your bagels and those unhealthy foods. Stay away from Chick-fil-A, things of that nature. Medication, talk to your doctors about that. They may not want you to take certain medication if you're getting the injection. They may not want you to incorporate vigorous exercise into your routine while you're undergoing injection. Are other treatments available? Yes. The injections, like I said, are treatment. If the patient doesn't respond, there's other forms of injection. And of course, laser treatment in the back of the eye to the retina has been used as well. And of course, close monitoring every month with your doctor, every 2 months, every 3 months, every 4, 6 months is really necessary to monitor you for improvement. For those patients who have advanced macular degeneration, their vision has been compromised. They have visual function decline or loss. Vision rehabilitation is important. Sometimes that's working with a team of other healthcare practitioners, the occupational therapists, the physical therapists, nutritionists, just making sure that everyone is helping the patient kind of navigate this new normal for their lives. Low vision devices can help with vision rehabilitation, magnifiers, high-powered lenses to help the patient read, large print, computers with speech output systems so they could read for the patient audiobooks. talking watches, clocks, and calculators are just some of the things that can be incorporated to help our patients navigate the loss of vision or functional decline that they have experienced. Now, really quickly, I'm going to answer all the questions in the chat, but the NEI, NIH has a lot of resources on macular degeneration as we talk about Healthy Aging Month. Don't lose sight of age-related macular degeneration. You can find educational brochures and information. Again, May's Healthy Vision Month. We also have resources on healthy vision as well. Other information, on NEI website, eye condition and diseases. So you can look up diabetic retinopathy or glaucoma. You can see what I see virtually, so you can get an experience what a patient with macular degeneration might experience, what a patient with cataracts or diabetic retinopathy and glaucoma might experience. And then for some of our patients, we know that access to care might be challenging, lack of insurance, transportation issues. Here you can see we have some information on free or low cost eye care. Again, we have the National Eye Health Education Program resources on diabetic retinopathy as well as age-related macular degeneration and glaucoma. As mentioned, I'm co-chair of the Eye Health, My Health initiative for African Americans, and this is really focused on education and information and outreach on those diseases, that disproportionately impact African American, those eye diseases such as glaucoma, diabetic retinopathy, cataracts, and of course, macular degeneration. Can impact the back of the eyes as well in our minority patients. High blood pressure changes in the back of the eyes, high cholesterol changes in the back of the eyes. So you can learn more about how eye diseases affect the African American Black communities and what are some healthy habits that you need to incorporate routinely to make sure that your eyes are healthy and that your overall body is healthy. And then, of course, you want to connect with us and NEI on social media. So these are some of our resources. So with that being said, I'm going to take all the questions in the chat because I see there's a lot. And if anyone else has any questions, please do not hesitate to ask Miss Lewis. So I see one in the chat. I think it does blue light protection on glasses help to slow age-related macular degeneration. So as I mentioned earlier, the short wavelength of light, your blue light from your computers, your iPads, and your iPhones can be damaging. Studies have found that they can be damaging to the eyes. That's why we're recommending patients take breaks from their computers, not to spend a lot of time on their computers and their iPhone. But yes, you can get that blue filter, that blue light protection on the glasses. So we do recommend that, or I recommend that for my patients that have age-related macular degeneration. Are there any other questions?
Dr. Reynolds, I was just going to jump in. I did see some other questions in the chat, so I was going to kind of help you navigate some of those. There's a question, since you were talking about the blue light. Someone asked, what about UV rays from the sun?
Yeah, so as I mentioned earlier, another risk is the UV rays can be damaging. We know that the UV rays can impact the eyes. It can lead to cataractus development earlier. So if you're out in the sun constantly, you can definitely, we all get cataracts, but you can get them earlier onset because of UV or lack of UV protection. So in patients that have age-related macular degeneration, lack of UV protection can exacerbate or make worse their condition. So yes, they should have UV protection in their glasses. So if they're out in the sun, they should have, sunglasses on that have UV protection, or a good pair of sunglasses that has UV. So I always tell my patients, the flea market 2 for $5 doesn't have good UV. There are some sunglasses that are sold at Walgreens or other drugstore like a Foster Grant. Those have good UV, but not enough. So I'm not saying you have to spend $500 on a pair of sunglasses, but a good pair of Ray-Ban that has good UV protection is important.
And now that same individual, I'm going back to the UV rays. They said even in prescription glasses. So I'm going to guess they mean if the prescription glasses have UV protection. Is that okay?
Yes. So when
Okay.
you get your prescription from an optometrist or an ophthalmologist, when they take it to the optical to get it done, they're always going to recommend UV protection. So it always comes standard with UV.
And then another question we have is, does AMD affect your circadian rhythm? So does it affect, I guess, the way that an individual would sleep or rest because of that?
So yeah, so let me tell you that sleep is becoming a big factor in eye diseases, right? So we know sleep apnea in the new diabetes 2024, standard of care is important to address because sleep apnea can exacerbate or make worse diabetic retinopathy, and it can also lead to diabetes. So sleep is an important component. We know lack of sleep or poor sleep can lead to systemic diseases such as not just diabetes, but high blood pressure, high cholesterol, just a worsening of those diseases as well. And because you have those conditions, you can impact your macular degeneration, right? You can make that worse. Again, patients' sleep is important to their overall eye health, their metabolic status. So yes, getting good sleep is important in patients that have macular degeneration.
Okay, I've got another question for you. Can a person get AMD in just one eye, or will it occur in both eyes?
So as I mentioned earlier, age-related macular degeneration is a genetic disease. It's, of course, the risk is older age, but it usually occurs in both eyes, just like glaucoma. You're going to get the disease in both eyes. In some cases, one eye might be worse than the other eye. So you may need an injection in one eye, or you may have advanced changes in one eye as opposed to the other eye. So these diseases that we mentioned, diabetic retinopathy, glaucoma, cataracts, age-related macular degeneration, typically occurs in both eyes. Yes, sometimes unilateral or asymmetric presentation, but it definitely occurs in both eyes.
Okay. Now another question is, it's two-part. What was the name of the eye-friendly vitamin? And would you suggest we take this even if we don't have age-related macular degeneration?
So what I will say to patients is if they don't have AMD, but they have a family member that has AMD and they're worried about getting the disease, eating healthy is important. Multivitamins, you can just take a multivitamins. In fact, Centrum over 50 has lutein and zeaxanthin in it for patients. So some of these eye-friendly, these multivitamins have some components of the eye-friendly vitamins in there. So you don't have to take AREDS supplementation specifically. You could take Centrum over 50. If you have early disease, then I recommend multivitamins for sure. If you have intermediate disease, I would definitely recommend the AREDS. So I'll tell you to take the AREDS 2 formulation. And what's the difference between AREDS 1 and 2? AREDS 1 had beta carotene in it, and if you're a smoker, beta carotene didn't work well with smokers. So that's why AREDS 2 is the best one to take. And AREDS 2 has the lutein and zeaxanthin and no beta carotene in it. So if you are going to take eye-friendly vitamins, if you know someone has macular degeneration, they should be on an AREDS 2 supplementation.
Okay. Another question for you. You did mention and you provided us great resources about visual aids if we do have changes. You gave us some information about the resources that were available. But does insurance cover these resources for low vision devices that you mentioned?
Some insurances will, some insurances won't. So it depends on your insurance. But your practitioner will work with you. Again, age-related macular degeneration is the leading cause of vision loss, blindness in our older individuals. And so we know this disease progresses. Our goal is to slow it down and to improve the patient's quality of life. And even once they have functional loss of vision, the goal is to improve their quality of life. So, our practitioners will work with the patient. Again, they may have magnifiers. There's so many things now available for our patients that can help them improve their quality of life. When I was in school 20 years ago, we didn't have iPhones and iPads. Now the patients with AMD can enlarge the print on those devices, on their computers. They can, before they had to write checks, now you could do electronic banking, so you have a larger font when you're working with that. And that's what a low vision or vision rehabilitation doctor will work with the patient on, those devices, how to use those devices, access to for training. Here in Fort Lauderdale, we have the Lighthouse. The Lighthouse is a service that helps patients with functional loss of vision or blindness, to help them to navigate the stove area, help them incorporate in their home ways to get the larger dial so they could see the dial on their stove, things of that nature. So it's not just the magnifiers, it's so much more when it comes to low vision and vision rehabilitation. And again, we work with a team, and part of that team includes occupational therapists, physical therapists, and others.
Okay. Now, how often should you be screened for AMD, particularly if you know you have risk factors? The family history is particular.
So if there's a family history, so genetics plays an important role. If patients are taking any of those 23s and me's and, these genetic testing, and they see that they do have AMD, they should definitely get an eye exam. I recommend everyone get an eye exam every year, a comprehensive dilated eye exam. That's the only way to detect the disease early. We could see those subtle signs in the macular area. We could take photos of that. So everyone should be getting a yearly comprehensive eye exam. And as you get older, it's more important to get a yearly comprehensive eye exam. Once you're diagnosed and your stage, whether it's early disease, intermediate disease, you want to be followed and closely monitored. So your eye doctor might see you every 3 to 6 months, just to make sure there is no changes. Once you have advanced disease, as an optometrist, I refer to a retinal specialist. So I work closely with a retinal specialist. The patient will need injections in the eye, but I also bring the patients back because these patients might have progression and might need low vision or vision rehabilitation while they're getting the injection. So we tend to see them closely and monitor them closely every 3 months.
Okay. Now I have probably about 2 more, but does AMD graduate into total blindness?
So as I mentioned earlier, it doesn't cause total blindness because you have your peripheral vision. It's that central vision. So when I'm looking at this monitor right now and looking at you, that's my central vision. When I see your face, that's your central vision. So AMD affects that. It causes that to be blurry, or you lose your central vision so you can't see the person's face. So if I ask you to read an eye chart, you can't read it because that's central vision. But they can still see things off to the side. They may see a hand over here, or peripherally they'll see things. So it doesn't cause total blindness because you may have some peripheral vision, but as the disease progresses, the periphery can become involved and it can cause loss of vision.
Okay, there was one more question. Does the optic nerve detaching, I think it is, does the optic nerve detaching, is that a symptom of AMD?
So the optic nerve doesn't detach, and macular degeneration doesn't affect the optic nerve, it affects the macula. So if I were to go back to, some of the images that I showed, this macular area here in the center. If there's fluid in the macula, if there's bleeding, it causes the macula to swell up. So yes, if that macula kind of swells or there's fluid there, or it sort of detaches a little bit, yes, that will affect your vision. And it would cause symptoms of blurred vision. If there's fluid there, it would cause wavy lines in the vision, or wavy lines on an AMSA grid testing.
Okay. And while you're on this slide and there's a visual, I think you answered this question, but it's in the chat and I just want to review it. Someone asked, can the bleeding be treated or stopped?
Yes. So once you have the wet type of macular degeneration, the treatment would be injections in the eye. Remember, we talked about the injections that you would get. You can either get monthly injections every 2 months, and now we have available to us every 4 months. So you may see commercials about certain eye injection for macular degeneration. That will help to stop the bleeding, slow the bleeding down. Can it reoccur? Yes, it can. So again, the patient might need more injection in the eye.
Okay. So I know, Dr. Reynolds, I said last question or two, but there's two more that popped up. And then after these two, we're gonna probably have to end the questions because I want to be respectful of Dr. Reynolds' time. And I know that she has to get out of here, but she did a great job. And so we definitely appreciate it. But the last two questions, the first one is, could you speak to if eye exercises help with eye health? That's question number one. And then the final question would be, do blood thinners increase the chance of eye bleeding?
So, as I mentioned earlier, exercise is so critical in overall eye and body health, right? We talked about obesity being a risk factor, but it's really also sedentary lifestyle, not moving. If you're just in your house and you're just in front of the computer all the time, you're not as healthy. So I always say there's skinny fat. You don't always have to be obese. You can have, you can look normal, but you're just sedentary. So exercise is really, really important. And increases your metabolic rate. It improves the overall health of the body and the eye. So yes, patients with macular degeneration, one of the things that we do talk to them about is, exercise, eating healthy, good nutrition, supplementation, multivitamins if they have the early disease, your green leafy vegetable. Those are really important. Taking their medication for their blood pressure, taking their medication for their cholesterol, and taking their medication for their diabetes. If you are taking a blood thinner, baby aspirin, Coumadin or heparin, and you have a bleed, that's something to really talk to your doctor about. I usually tell my patients that it depends on, some patients need that medication. So yes, it can, because it can thin your blood. But if the patients, we're working with their cardiologist and their treating physician, they may or may not need to stop taking those medications. Does that make sense? As we treat them. So again, this is a multi-team approach in addressing these patients and treating these patients. It's not just the optometrist or retinal specialist, but it's also their treating physician that we need to communicate with. So yes, it should be considered, and that's medications or drug you should talk to your doctor about.
Okay. Okay, well, Dr. Reynolds, we definitely appreciate this. This was a great presentation. I, in fact, learned a lot from you, speaking on age-related macular degeneration. We hope that the audience enjoyed it and learned a lot. Ms. Tellisford put her email address in the chat there if you need to reach her. I'm going to hand it back over to Ms. Tellisford to wrap us up. But thank you so much, Dr. Reynolds. We greatly appreciated you. It was so informative.
Thank you for having me. It's such a pleasure to be here.
Yes, thank you, Dr. Reynolds. So appreciate you. You have to go on to graduation. And thank you, Miss Lewis, Keisha, as I call you, for facilitating our questions and answers. Thank you so much for attending and participating in the chat. We appreciate you. This was such a great and informative presentation. Thank you for coming. Have a great day. Thank you so kindly. Bye-bye.